Now, very, very quickly, allow me to go straight to the next session, which is maintaining essential health services during a pandemic, integrating a COVID-19 response into rural access initiative in Zambia. This session is going to be led by Caroline Barber, the Chief Executive TransAid. Allow me to read the title of this session again, and this is Maintaining Essential Health Services During a Pandemic, Integrating a COVID-19 Response into a Rural Access Initiative in Zambia. Caroline?
Good morning, good afternoon, and good evening. I'm really delighted to be here with you all today as part of the Flown Initiative and this important Women in Transport conference. My name is Caroline Barber. I'm here with my colleague Auxilia Perigondo, and we have the privilege of sharing some experiences from you, with you about maintaining essential health services during a pandemic. We're going to be talking to you about integrating a COVID-19 response into a rural access initiative in Zambia and sharing experiences from Mammoth Scale. You can see the logo here. Mammoth Scale its full name is Mamas Against Malaria at Scale, and it's all about tackling severe malaria and maternal health and integrating a COVID-19 response in Zambia. So just a little quick overview of who I am and who my colleague is. My name is Caroline Barber. I'm the Chief Executive of an NGO called TransAid, and I've worked in transport and logistics for over 16 years. I'm really pleased and have the privilege of also being a senior technical advisor to the Mammoth Scale programme. My colleague Auxilia is also joining us today. Auxilia brings over 12 years of extensive experience in both qualitative and quantitative research for evaluations in low resource settings. Auxilia is also the Director for Development Data, another of the consortium partners with TransAid in Zambia. She has a lot of experience in managing national surveys in Zambia and other countries, and in Mammoth Scale she has led on many of the surveys that we've done, as well as Development Data being the lead organisation. So introducing Mammoth Scale. So Mammoth Scale, the Mamas Against Malaria, shortened to MAM programme, it's an innovation, a severe malaria innovation targeted to children aged 6 months to 6 years. And this is the group, the age group most at risk of contracting severe malaria. It has been an 18-month intervention running between December 2018 through to May 2020. Mammoth Scale built on a previous programme that was a small pilot, the MAM pilot, that ran for a year in 2017 and had some really exciting and promising results. So we've been working to scale ever since. We received an extension. Our partners and donors have been extremely flexible in the COVID-19 context, and they actually gave us a no-cost extension to run from June to November 2020 to actually carry on the severe malaria work, but to integrate some COVID-19 response activities. We were also fortunate enough to receive funding from the FIA Foundation, who came in as well to support the funding we already get from Grand Challenges Canada and Medicines for Malaria venture to help. And actually that was since April of 2020. They were very quick to respond to see how we could do some really targeted and urgently needed prevention activities. We've been working in partnership with the Zambia's National Malaria Elimination Centre and really closely with the Ministry of Health, particularly in the districts, with the District Health Management Team, or the DHMT. Oh, before I move to the next slide, let me mention the consortium partners who are working together to make this work possible. On the bottom of the screen there, on the left, we've got the Ministry of Health, of course, or the government of Zambia. And then one of the partners, the organisation I work for, TransAid, and we are an NGO focusing on transport and logistics solutions in sub-Saharan Africa. Then we have DI Global Health, who are bringing considerable health expertise to the consortium. Development Data, the organisation that Auxilia works for, who have real specialisms in monitoring, evaluation and learning. And then we have Disacare Wheelchair Centre, who are doing fantastic work helping build the emergency transport vehicles that we're using in this programme. A superb Zambian-based organisation. And then, as I already mentioned, Medicines for Malaria venture there. So where are we working in Zambia? We started in Serenje district that you can see on the map here in blue. Then we scaled to Chitambo in the north, And then this year, we've also been working in Manyinga. We've also been working over in the east in Chama and also in Vubwe. So you can see we're working in quite a few different parts of the country that all bring their own different contextual sort of issues and challenges that we're able to work with the districts and respond to. So I now want to move on to, this is the Women in Transport Conference, and really focus on some of the transport challenges. What we see in many parts of rural Zambia is that rural communities encounter many delays in accessing treatment for severe malaria in children. And the MAM program is actually a follow-on from a maternal health program, which was originally mobilizing access for maternal health services in Zambia. And so we've been able to really build on this strong evidence-based program of trying to support pregnant women accessing healthcare services when they need it most. So during pregnancy, and if there's any complications, and for delivery and for follow-up care. And we also see for small children too, or the age groups most at risk, that severe malaria can come on so suddenly, and really tragically, 90% of children, if they don't get to a health facility within 24 hours to get essential treatment, then we see too many preventable loss of lives. So too many avoidable child deaths, and in the previous work and the work we're carrying on now, avoidable maternal deaths as well. So this is really why we're focusing on really addressing the access challenges. So some more of the barriers and delays that we see. These can be challenging terrain. These can be people living in remote and rural areas where a four-wheeled vehicle is not able to easily pass through. There can be, transport can be expensive. There can be a lack of affordability in that regard. There can also be delays around why to travel to access healthcare, low awareness of what the severe malaria or maternal danger signs are, a lack of the actual physical modes of transport that are there and available. And another issue we see as well is a lack of food for carers and patients if they make that decision to travel to a health facility and could be there for many days. So these all contribute to the barriers and delays that we see. So I want to focus now on bridging the transport gap and touching on some of the emergency transport systems that the Mammoth Scale programme has been working on. So one of the things we've been doing is our approach is always to look at what transport is available, what are people comfortable using, maintaining, accessing, and we really build from there. So Transaid has different sort of emergency transport schemes in different parts of the world, but in Zambia, in the countries we're working in with Mammoth Scale, we've really been focusing on quite a low-tech solution, the bicycle ambulances that you can see in the photograph here. So the bicycle ambulance trailer and stretcher is actually produced by Disacare, the Zambian NGO I mentioned before, and they have over 15 years experience of building these bicycle ambulances and close collaboration with MAM at Scale. We purchased the bicycles through World Bicycle Relief. They provide the Buffalo bicycle, extremely strong and robust and fit for the terrain. And Mammoth Scale has supplied over 90 bicycle ambulances to rural communities. 80 have already been dispatched and are in the communities, and 10 are currently being manufactured and will be rapidly deployed. The stretcher that you can see can be detached from the frame, and this makes it quite useful for actually lifting to carry over if there's any small streams or areas that the bicycle ambulance can't pass. So that's quite a useful function. You can see it's got a canopy there, provides protection and privacy for pregnant women or for small children, and it also gives protection from the sun or from the rain. The design has been adapted over the years for good, make sure now it has good ground clearance. You can see on this model that actually the canopy rises a little bit higher, and that's so that you can actually have a caregiver and a child together in this one, a little bit more space. As I mentioned, the bicycles and the trailer really robust and durable, with the trailer being locally manufactured by people who understand the terrain it's going to be used on. It means we've got a good supply chain and accessible spare parts, and we obviously train the communities on the maintenance aspect too. Each bicycle ambulance has been supplied with some tools of the trade. So we have some, you can see the reflective jacket there that one of the riders is wearing. And they also have lights attached to the bikes for the dynamo, basic tools, and a logbook for keeping a record and recording the different trips made to feed into our wider community monitoring systems. So that's on the actual physical vehicles, but of course there needs to be a community managed system here as well. So mobilising actually not just riders, but whole communities around the emergency transport system. So the riders and custodians, the people who are going to look after the vehicles, are nominated by the community. And there's a really good engagement with the community on actually who's allowed to access the vehicles, how they do that, making sure they're available day and night. And the community are completely responsible for the maintenance, looking after the bicycle ambulance and making sure that they're used for their intended purposes. The district health management team, we work really closely with them as well. Although these are community managed assets, there's a very clear line into DHMT so they can give that support and make sure that they follow up from time to time, see how the community is getting on and all the support with a dedicated focal person in the district who is the key link for the bicycle ambulances. I won't, because of time, I won't go into too much more detail, but we train 2 ETS riders per bicycle ambulance. They cascade down, and it's quite a comprehensive training package. And as you can see from the picture here, the communities are involved in the assembly, which is great for meaning that they know the sort of nuts and bolts of how the bicycle ambulance system works. And what I'll do at this point, I just have a couple of slides left before I hand over to my colleague Auxilia. But I'd love to show you just a very short film about the pilot project, the MAM project that was conducted in 2017 to hopefully bring some of this work to life for you. So this film was actually made by the Bill and Melinda Gates Foundation as an example of some really promising innovations in the malaria space.
Severe malaria in left untreated or unchecked can result in death, especially within the first 24 hours. The majority of lives lost to malaria are those of children who live quite far from health services.
How do you save children who are living in remote communities who are suffering with severe malaria?
Here in Zambia, we're using an already existing form of malaria treatment, artesunate. In this case, it's in the form of a rectal suppository. This is a life-saving form of drug. The initial dose allows time for the sick child to be transported from the remote area that they're coming from to the health facility where they can access more treatment.
Zambia is a very big country with about 752,000 square kilometers. Some villages can be as far as 50 kilometers to a health facility. If you have to get the child to the health facility in time, there must be a transport system in place. These bicycle ambulances are a much better mode of transport because they need to be transported in a very, very proper way so that you don't complicate the condition.
By the time they're reaching the health facility, at least they are stabilized. Now at the facility, we usually give injectable artesunate in order to complete the treatment.
Nakireta omwana ku kipatala nakimuleta n'okumundapa bamundapa n'omwezi omukikwete bakola batipityawo naye.
Since the introduction of this anti-malaria drug, we've seen a huge reduction of death in children under 5 in remote areas.
By improving access at community level, we can save more lives, which has been proven already in Zambia. Now that there's a World Health Organization quality assured rectal artesunate suppository, this has the effect of improving our fight against malaria. Currently, 29 countries have introduced this form of treatment. This is one of many innovations that we need in the next 5 years in order to beat malaria.
So I hope that film helped to bring to life some of the work that we're doing in Zambia, and the stories that some of our amazing colleagues, the amazing community health volunteers and emergency transport scheme riders and colleagues from the Ministry of Health are doing to make sure that people carry on accessing health services. And this has never been more needed than during COVID-19. We need to make sure that children are still able to access essential health services so that in the fight against malaria can continue, so that pregnant women can deliver safely, and so that communities are supported in this way. And I just want to finish my part of the presentation with this final slide, which shows an incredible emergency transport scheme rider, Josephine here, Josephine Mapeta. She's from Serenge, and she is one of the volunteer emergency transport scheme riders. So Josephine is a pure volunteer for her community. She's motivated to ride the bicycle ambulance and provide transport to her community in a context where there's very limited other transport options available. She has her own personal motivations for being an emergency transport scheme rider, built on the loss of a family member that she felt a death could have been otherwise prevented. She's an incredible woman, full of life, incredibly energetic and dynamic, somebody who inspires me. There's a quote directly from her above on the right-hand side of the screen that I'll just read out. "The bicycle ambulance is the best thing that has happened to this community. I see people going about their daily lives in my community who otherwise wouldn't be alive today." So I just wanted to take a moment to recognise and appreciate the work that Josephine Mapeta and over 1,300 other community health volunteers are doing. And they have been some of the first people to step up to volunteer again to help their communities and keep them safe in the fight against COVID-19. So thank you so much for listening. And I will at this point hand over to my colleague, Auxilia Peregondo, who will take you through the next part of the presentation about our COVID-19 response and our gender-based work and gender-based violence counter work in the context of MAM at scale. Thank you so much.
Good afternoon, everybody. My name is Auxilia Peregondo. As Carol mentioned earlier, I'm the Director for Development Data in Zambia, which is a partner in the Mammoth Scale project. Carol has given a background on what the project is all about, and I'll be focusing on integrating a COVID-19 response at speed. As we all are aware, Zambia has not been spared from the COVID-19 pandemic. The first case was actually reported in March 2020, and COVID-19 has also spread to other districts in Zambia. It is in this vein that Mammoth Scale decided to integrate a COVID-19 response at speed. The activities that we are doing in response to COVID-19, Mammoth Scale is supporting the Ministry of Health to develop national community engagement guidelines. We are also working hand in hand with the district health management team. In our efforts to fight COVID-19, we are engaging traditional leaders who are community influencers. So we are engaging them in all our activities. And we have materials that we've distributed. These materials are translated in local languages so that we're able to cater for everybody and that nobody is left out. We also have community radios where we give information about COVID-19, how to prevent it, and the numbers for calling when somebody suspects that they have COVID. And people are also able to give feedback and call in for the live sessions during the community radios. We also provide clear, reliable information from trusted sources. We move on to the next slide, prevention and response in the community. The picture on my left gives a detail of the guidance for ETS volunteer riders during the COVID-19 pandemic. We are supporting the volunteers and training them to build a sustainable capacity. Our response as Mammoth Scale to COVID-19. In July 2020, we conducted a survey. It was a midline survey of the project, and we found that 94% of the trained CHVs felt confident that they knew the main signs and symptoms of COVID-19. Mammoth Scale is oriented more than 1,300 volunteers. And these volunteers helped to cascade the training down to the wider communities. Over 350 communities have been supported. And we also have saving schemes in 200 sites have now received support. Over 5,000 COVID-19 posters have been produced across the country, and these have been translated into the local languages as well. Radio spots, as I mentioned earlier, and the discussions are on air, and we include topics such as the increase in gender-based violence in a pandemic situation. Despite health sector challenges with delivery of facility and outreach services, the CHVs have continued to support severe malaria, which is what the project is all about, and other child health emergencies during the pandemic, with 1,094 and 391 cases managed respectively between March and August 2020, and 1,028 children have been transferred from the health facility by bicycle ambulance. Over 300,000 people reached with the integrated COVID-19 and severe malaria response. As you can see from the picture, while we conduct our trainings, we also ensure that we observe the prevention protocols. People are wearing masks and they're also practicing social distancing. We ensure that they are a meter apart when we carry out the trainings. The Anti-Based Violence Act was first published in Zambia in 2011. The Act covers any physical, mental, social, economic abuse of a person, either men or women. And it also talks about harmful traditional practices, such as female genital mutilation, female genital cutting, and early marriages. We have 7 gender smart strategies that underpin Mammoth Scale's work. The National Gender-Based Violence Statistics in Zambia. So I'll just give you a brief demographic health survey. 49% of the women in Zambia, it is reported that they've experienced some form of violence, either from their husbands or partners. More than a third of women, which is 36%, have experienced physical violence at least once. 32% of women aged between 15 and 49 years have reported that their partners have demonstrated at least 3 signs of the behavior. Few women seek help if they are victims of gender-based violence, of which 80% of women are said to suffer from sexual violence and do not seek help. 66% of women who suffer from physical violence do not seek help. With the coming of COVID-19, there are real concerns that many women will not survive the pandemic. There is low involvement in children's health, but primary decision-making power, and this leads to delays in people seeking health services. Unequal access to information as well also leads to a delay in seeking health services. And women also lack financial resources as well. There's lack of social support, impacting some women's ability to take care of themselves and their children. Our gender strategy development process is shown by the figure on the slide. Start with the desk review, and then we move on to consultation, and then the initial gender analysis, and then gender empowerment theory of change, the gender strategy, the vision, priorities. It also talks about the implementation. It talks about the plan and the indicators as well. The gender smart strategies, as you can see from the picture here, The vision is that women and girls will be more confident to make health-related decisions and challenge healthcare delays, leading to improved health outcomes among young children. The first strategy, using an inclusive participatory community engagement approach to mobilize communities around a severe malaria agenda. Secondly, empowering communities to establish and manage their own systems for addressing severe malaria barriers and delays. Thirdly, addressing social norms that disempower women and girls in community discussion groups and other volunteer activities. The fourth point, placing a strong focus on male involvement and acknowledging that women and children's access to health information and services is contingent on supportive gender relations. The fifth item, adopting a whole community approach so that women and girls are reached and empowered, including the socially excluded. The sixth item, training large numbers of community volunteers to ensure every woman and every child can be reached, and to create a network of both male and female role models who positively influence the community change process. The last item, creating an enabling environment for women's and girls' empowerment by involving traditional leaders in the change process, encouraging changes to local bylaws and directives. We move on to gender-based violence activities in Mammoth Scale. The picture on my left details what is gender-based violence, the impact of GBV. So we share this information with the communities, what they can do when they hear about GBV. They call toll-free number, which is 993. And they are also informed that support is available 24/7 from Lifeline Zambia. Cases of GBV were in danger of rising in the context of COVID-19. Mammoth Scale and DHMT embarked on sensitizing the communities through the radio. GBV programs were live phone-in programs. The activities were timely as people needed more guidance on how to survive GBV during the pandemic, which was reported to be on the increase. More information, including a brief and copies of the materials and posters in multiple languages, can be found on Transaid's Knowledge Center, and it's all open access. As I mentioned earlier, we conducted a midline survey this year in July, and we also did a baseline survey in February 2019, and the results from both surveys done, both the baseline and the evaluation are as follows. The population coverage, we targeted, we intended to target 115,000 people, but we actually managed to reach out to 320,000 people. Changes, one of the indicators was changes in knowledge and confidence. CHVs, we found out that CHV's knowledge of causes of malaria, it increased. At baseline level, it was 71%, midline, it was 99%. Female CHV's knowledge of severe malaria danger signs at baseline, 72%, 99% at midline. CHV's confident to administer RAS, 42% at baseline, and at midline, it was 98%. Malaria case management, CHVs who managed cases of malaria at baseline, 79%, midline, 93%. CHVs who referred children with severe malaria. At baseline, we found 56% and 91% at midline. Gender empowerment. Female CHVs who felt that they had a strong voice in their communities was at 98%. And female CHVs who felt that female community members had more independence to make health and other decisions at 92%. Children with severe malaria who received RAS was another indicator. At midline, it was 3,216. A fall in the proportion of simple malaria cases progressing to severe malaria meant that the number of children presenting with signs of severe malaria and receiving RAS was lower than expected. A proportion of simple malaria cases progressing to severe malaria was found to be 2.2% at baseline and 1.1% at midline. And we calculated that the estimated lives saved was at 193. Target 50% of community health volunteers. That was our target, and the results that we achieved. Serenje and Chitambo, which were the implementation districts, with 52%, and the scale-up districts, these are fairly new districts, with 20%. We are implementing in these 5 districts. But Serenje was also the pilot site, and then Chitambo was added, and then later we added on 3 scale-up districts. That's why the number is a bit low, but as we progress with the project, the numbers will also likely increase. Also, it would be good to point out that when we moved on to the scale-up districts, we're working with other partners, and the community health volunteers had already been selected. So we didn't have much say in that. But however, we'll continue promoting female community volunteers to take up in the project. The target was 15% for female riders, and I'm happy to say that the result we got is 34%. Female riders are actively encouraged to volunteer. We will move on to changes in women's decision-making capability. These are some of the quotes that we got from the female community health volunteers. Women are aware of their rights and won't be kept at home. Women are now making the decisions and men are supporting them. Another community health volunteer was quoted as saying, women are no longer waiting for husbands to give permission for them to go to the health facility for themselves or for their children. Previously, women never took that decision. They used to wait for their husband. Now this has changed. The entire community has changed. Our next steps for next year for 2021. We are adding 5 more districts to the already existing 5 districts, meaning we'll now be implementing in 10 districts. The potential districts are in Eastern, which is the district is Petauke, Northern Province, and the district is Kasama, Northwestern Province, and the district is Minalunga, Luapula district, Luapula Province, and the district is Mansa. The 5th district is yet to be confirmed. We'll continue providing further support in Chama, Manyinga, and Wobwe. And support will continue in the other 5 districts as well. If you have any questions or queries or comments, please share them, and this will be answered during the Q&A session. Thank you.
Thank you very much for that very informative session, Caroline, Baba, and Auxilia. I don't know if they're tuned in right now with us. Can either of you hear me, Caroline or Auxilia?
Hi, I'm Becky. Yes, we're both here. We've both been following. Thank you so much.
Fantastic. Thank you so much for quite an informative session. Do you have any closing remarks just as we're about to wind this up?
I don't think so, unless I'd like to give Auxilia the chance, if we have a couple of minutes left, if there's anything Auxilia would like to add. Some of the slides at the end, I think on the pre-recording didn't fully come through, but if there's anything, Auxilia, you want to add to your presentation?
Okay, no problem. Thank you very much, Caroline. That was quite informative. And that brings us to the end of that session, and actually to the end of our conference today. We'd like to thank everybody that was able to join us today.